Good evening, everybody, and apologies for not being with you in person. My name is Ramani Moonesinghe. I'm a professor of perioperative medicine and a consultant anaesthetist at UCL Hospitals and the National Clinical Director for Perioperative and Critical Care at NHS England. It's a real privilege to be able to talk to you about the preoperative pathway. I'm going to focus on three areas around improving pre-op assessment. So the timing of pre-op assessment, the proportionality of it, I'm going to cover very briefly, and then the methods that we use for pre-op assessment and in particular for assessing risk in patients undergoing major surgery. So I lead the National Perioperative Transformation Programme at NHS England, and this is an overview of the areas that we're trying to address, and you can see that there's a lot of work going on in the preoperative pathway. We know that we've got this major challenge with the elective recovery challenge, and more than 7 million patients waiting for treatment. Of those, about 20% are waiting for surgery, and of course of the other 80%, many of them will go on to have surgery after they've had their first outpatient's appointment. So the aims of what we want to do are to improve the preoperative pathway in order to improve patient outcomes, importantly to reduce last moment cancellations, increase the proportion of patients that are suitable for treatment in high volume and low complexity hubs, reduce variation in day surgery rates. And through doing all of this, the mechanisms by which we want to do some of this include early screening and optimization, implementing prehabilitation, and implementing surgery schools. And in all of this, a very, very important part of the preoperative pathway is to improve shared decision-making and the informed consent processes. And I'll touch on those in a moment as well. These data from just over a year ago from a service evaluation undertaken by the Health Services Research Centre found that in 76% of trusts in England which participated, there was a 17% on-the-day cancellation rate over a 2-day service evaluation. And 3.5% of all patients due to have surgery, so about 25% of that 17% cancellations, those patients were cancelled due to avoidable failures of preoperative process, either because the patients were medically unfit due to long-term conditions, or in some cases, in a smaller number of cases, because the surgery was no longer warranted. The patient decided that they didn't want it anymore, or the surgical team decided that surgery was no longer the best option for the patient. So we think that approximately 250,000 procedures per year are cancelled for these avoidable reasons. And this, alongside everything else, is a really important reason to rethink the way that we deliver the preoperative care pathway. So this is an overview of the pre-op care pathway in most trusts as it stands today. We have a GP referral, usually at the primary secondary care interface there at the beginning. That results in a review by a surgical team. And if they think that the patient is suitable for surgery, and ideally, hopefully, if they've been through a shared decision-making process, the patient is put on the waiting list. And then they wait and they wait and they wait until a few weeks before the operation, and after a date for surgery has been agreed, they are sent to preoperative assessment, during which they have their first real assessment of their holistic health. And then only at that point do we sometimes uncover some significant problems. If the patient's lucky enough to get through that process without a delay to their operation, they have their surgery, and there's big variation in day surgery rates. They go on to whichever post-operative care venue they're best suited to, ward care, and then outpatient follow-up. So you can see, and you'll all be experiencing in your own hospitals, the challenges there are with this pathway from a clinical and an operational perspective. That first interface between primary and secondary care, all the communication is with the surgical teams and not with the perioperative team, which means that we lose time in terms of identifying critical health issues. Then the patient waits and nothing really happens to them while they're on the waiting list. And so they come to pre-assessment, which is a face-to-face usually and resource-intensive process, within 4 weeks of their to-come-in date. And the patient's already been given a date for surgery, even if they're not clinically fit. So we're then faced with that dilemma of whether in patients whose health is not good, whether to proceed because the surgery is urgent and we need to get on with it, or the patient's waited a long time, or whether we delay or postpone them. And that, of course, has huge cost to the patient and huge cost to the service. All of these things combine to cause last-minute cancellation rates. And then after surgery, we have problems that we all recognise in terms of lack of critical care beds and variation in the quality of care afforded to patients as a result of that, variation in day surgery rates, and poor implementation of enhanced recovery pathways, leading to an unwarranted variation in length of hospital stay. And the challenge of imperfect preoperative assessment is very significant, and right at the centre of it is one of the key aims of the NHS, which is to reduce healthcare inequalities and health inequalities. And the patients who are not identified early as high risk or who have health optimisation needs are more likely to be deprived. They're more likely to have protected characteristics such as non-white ethnicity. They're likely to have lower health literacy. And as a result of this, they're more likely to have delayed discharges due to inadequate discharge planning prior to surgery. And what all of this translates to is more complications, longer lengths of stay, more healthcare resource utilisation in the long term, and reduced long-term survival and health-related quality of life, as well as worse cancer outcomes in the patients having cancer surgery. So Emma McCone is working with the Getting It Right First Time team as a national non-medical preoperative assessment lead, and she's come up with this overview of what pre-op assessment should be trying to achieve. So pre-screening, which I'm going to come on to talk about in a moment, so identifying early the patients who require optimisation through partnership between primary and secondary care where possible. Then optimisation of the process, so matching supply and demand with the scheduling and booking teams. Protocols and guidelines to meet that every patient reliably gets the best quality care throughout their pathway, irrespective of who's looking after them. Patient preparation, including shared decision making. And then obviously what we want to be doing across the board is promoting excellence through targeted training and teaching. So Emma's leading a big initiative with pre-op assessment nurses and non-medical staff to try and address all of these areas. Perhaps more relevant to this audience is the changes that NHS England has proposed and which are going to be written into the standard contract, which is being published today for the next financial year, starting on the 1st of April. And that's the introduction of this stage in the middle here, which I put in a box, the early screening and triage stage, and the keeping in touch and optimisation. And underneath you see the writing there that was from the elective recovery plan published in February 2022. But as I say, this now has been enshrined in the new standard contract, and therefore there's an expectation that all trusts will be implementing this early screening and triaging process and the keeping in touch and optimisation process for all patients on inpatient pathways, starting with implementation at the latest on the 1st of April this year, so in a couple of weeks' time. So how do we suggest that this is done? So there should be better information sharing between primary and secondary care at the point of referral. We're working hard at national level to try and make this something that is equally available across the board through liaison between the primary care record providers, EMIS and System 1 and TPP, and secondary care teams. But equally at local and system level, many places have implemented a system, whether that's a technical system like having a health information exchange, or whether it's a simpler system of just having a standardised template for when patients are referred into secondary care, so that that information, that critical information, not just about the condition for which the patient is considering surgery, but also about their general health, their comorbidities and frailty and their dependencies and so on, can be shared with the secondary care teams. We also need to support patients to undertake their own questionnaires about their non-medical health. We know that GP records won't necessarily contain up-to-date and accurate information about things like smoking, alcohol, exercise, nutrition, weight, and so on. So asking patients to complete questionnaires about their general health is an important philosophy. We should be then screening and triaging patients, and I'll come on to how we might do that in a moment. And what we've suggested is that in order to enable all of this, we know that pre-assessment services are already under an enormous amount of pressure because of the elective backlog. But the introduction of a non-clinical role, which we could term the perioperative care coordinator, might support pre-assessment services in delivering these ambitions. I should say at this point that the fact that it's going into the NHS contract means that there is an opportunity for pre-assessment services and perioperative teams to access resources in order to be able to support the delivery of this plan. So if we were to undertake screening at the point that the patient, at the latest, at the point that they're added to the waiting list, one might anticipate that if we screen them at that stage through a combination of review of their objective medical health and also through self-assessment screening that the patients might undertake, that they would be triaged into potentially 3, broadly speaking, categories. The first would be those that are good to go. So they are ASA 1 or 2. They're often having not very big surgery, and they could then therefore be cleared as fit for surgery, given universal advice about smoking and alcohol and diet and so on, and then put on what we're calling a surveillance pathway where we keep in touch with them. And I'll come back to that in a moment. Then there's going to be a group of patients who require medical optimization. Their diabetes isn't that well controlled. There's something else that's been discovered recently that needs optimization. And if need be, we need to be able to facilitate specialist referrals. What's critically important is that every preoperative assessment service has some pathways that are standardized that will enable this medical optimization to occur. And I won't reel off a long list of those, but one might include, for example, diabetes pathways, anemia pathways, hypertension management, frailty pathways, and so on. And then finally, there's a very small group of patients really that are likely to benefit from specialised prehabilitation. And that might be those who need some exercise support, some nutritional support, or some psychological support. And across all of these, there are some universal themes: medicines optimization, health coaching, and social prescribing, which can happen in the community. So implementing this is likely to cost money, undoubtedly, because up front, we're going to be screening patients earlier while we're still having to cope with the patients that are coming for surgery in the next few weeks. So it's a trust and system-led decision about how to do this. But as the ambition is that inpatient pathways need to be covered by April next year, and we focused on inpatient pathways because we think that that's where the clinical and operational gains are likely to be the greatest, because patient fitness is important for surgical outcome, and also because it potentially lends itself to patients who are identified as having health needs, but who can be optimized, then being triaged back to day surgery or hub surgery. So in order to cover this ambition, we've suggested these perioperative care coordinators be implemented. Each trust will make their own decision about whether or not they need this. But the idea is that this is a suggested new member of the team, a non-clinical band 3, that will enable pre-op assessment teams, particularly nurses and non-medical staff, to work at the top of their license. To support digital enablement, if we ask patients to complete self-assessment questionnaires, lots of places will want to do this digitally, but lots of patients will need help. It's not that they can't do it, it's just that they might need a little bit of help accessing it and just being introduced into how to do it. And there's plenty of evidence from pilot studies where digital tools have been used in this context that you can improve the compliance with a digital pre-op self-assessment tool from around 25% up to 70 or 75%, just by having somebody on the phone available to help patients if they need it. And then finally, we want to make sure that patients have contact with us at least every 3 months while they wait on the waiting list. Because particularly patients who are older, or indeed any patient, things change. They develop a new health condition, something gets worse, something gets better. And so even though a patient might have been cleared as good to go on the 1st of January 23, by the time they come for their surgery on the 1st of November 23, things may have changed. And we want to not be surprised by that when they come for their final checks. And so the keeping in touch process, which could be very light touch, it could be a text message, it could be a phone call, it could be an email. But ensuring that patients respond to that might need some support from the coordinators. And that's the way that we anticipate that we'll be able to keep in touch with patients effectively. We think that you'll need about 1 per 1,000 patients per annum seen in your pre-assessment clinics, one of these perioperative care coordinators. And if you look at the benefits realisation of that, as I said earlier, more than 220,000 procedures a year probably are being cancelled at the last minute because we haven't quite got the preoperative processes right. And of course, we know that that's the tip of the iceberg because it doesn't include the patients who were cancelled 1, 2, 3, 4 weeks before the operation, having been given their TCI date. But if you just include those 220,000 procedures, and you think about £30 per minute of cancelled operating time if those patients can't be replaced, that's a likely cost to the NHS of over £700 million per annum. And we estimate the cost of implementation of perioperative care coordinators to be less than 50 million. And that doesn't include other savings, such as, for example, reduced length of stay because fewer patients have had post-operative complications. So the exact mechanism by which trusts implement this is going to be down to local service leaders to decide. That's down to you guys to decide how to do it. But there are 5 core requirements that we're asking trusts to consider and that we will be monitoring progress on. So the first is for all patients on inpatient pathways to be screened for preoperative risk factors as early as possible in the pathway. The second is that through this screening assessment, which takes place at the latest, as I say, when the patient has been added to the waiting list, we then identify patients who've got health optimization needs and get on with that. The third is the keeping in touch process that I've just mentioned, keeping in touch with patients at least every 3 months. The fourth is that patients should only be given a TCI date after they've been cleared by this early screening process to reduce the risk of the patient being cancelled. And then finally, we want to make sure in all stages of the pathway that patients are involved in shared decision-making conversations. And of course, this is going to be more important for the higher risk patients. There are some resources available. So the first one is on the Futures NHS website, which you'll all be able to access, but you do need to register to join. And then the second is where digital support has been able to support implementation of this early screening already in pilot studies. There is a digital playbook available from NHS England. You can Google it to find it, and that will give you some case studies. So I'm going to move on briefly now to how to do risk assessment, whether that's at the early screening point of the pathway or later down the line. Let's think first of all about what contributes to perioperative risk. So patient health and fitness fundamentally does. Functional capacity, comorbidities and frailty, and I'll come on to that more in a moment. Surgical urgency. Emergency operations are generally higher risk than elective operations. And the surgical magnitude is again one of the reasons why we've decided to focus on inpatient operations for this early screening process to be prioritised. Because although, for example, many 80 and 90-year-old patients coming for cataract surgery will have a long list of comorbidities and may indeed be very frail indeed, they don't necessarily need all of those issues to be optimised prior to having cataract surgery safely. So the magnitude of surgery is really important. Of course, the quality of care makes a massive difference to whether or not a patient will have a good outcome. But the quality of care can be informed by really good preoperative risk assessment. And the options for risk prediction include assessments of general risks and therefore the patient's risk of general complications or mortality. And for that, you can use a generic risk prediction tool, and I'll come on to talk about those in a moment. You can evaluate their functional capacity either using a questionnaire like the Duke Activity Status Index or cardiopulmonary exercise testing, which is particularly useful in the patients who've already done a Duke Activity Status Index and been identified as having lower than ideal metabolic equivalents. And then the risks associated with general health and fitness, for example, frailty. There are, of course, procedure-specific risks, which are best perhaps left to our surgical colleagues to discuss with patients, particularly localised risks such as urinary or sexual dysfunction and prostate surgery. And then, of course, there are specific generic complications, such as pulmonary complications, pain, and so on. Now, the accuracy of risk prediction tools for those sorts of complications is always less than it is for predicting mortality. And there are lots of reasons for that, including how we measure complications and the magnitude of them. And so just thinking about generic risk factors for particular complications, for example, if you're a smoker, you're more likely to have a chest infection or a postoperative pulmonary complication. That may be more important for triaging and deciding how we then optimize patients prior to their surgery, and indeed how we look after them in the perioperative period. So to give an example of that, this was a paper recently published by Richard Armstrong from Bristol, based on data from PQIP, analysing nearly just over 17,000 patients undergoing major surgery and finding an 18.4% severe pain rate on day one after surgery in this cohort, and finding that this was more prevalent in women, patients with cancer, or patients with insulin-dependent diabetes, current smokers, and those taking baseline opioids. So if you consider yourself sitting in the pre-op assessment clinic, either if you're a nurse or indeed if you're a consultant or a trainee supporting the pre-op assessment team, you might think, particularly in patients with diabetes who smoke or who take pre-op opioids, those are the patients who might benefit from a chat with your acute pain team prior to admission to hospital and establishing what the ideal pain pathway should be for them in order to reduce the risk of them having severe pain, which is associated with reduced drinking, eating, and mobilizing and compliance with enhanced recovery pathways, and also with longer lengths of stay. The commonest question that I'm asked about risk prediction models is, can you use a population-based risk calculator to predict individual patient risk? And the answer to that is yes, but you need to do it respectfully and with caveats. So all that using a risk prediction tool, like the PPOSM, like the SORT, like the ARISCAT for pulmonary complications does, is it narrows the limits of distribution when you consider a normal population of patients and the risks of them having a particular outcome. So over there on the left, you can see the normal distribution and the likelihood of mortality or some other adverse event in patients having an AP resection electively. And on the right, you can see how that's narrowed because you're considering just ASA3 patients with cancer having an elective AP resection. So the point is that just by adding those additional variables, you've narrowed the limits of distribution of any estimate that you make of the potential risk of an adverse outcome. So this is what you might consider to be a normal distribution for post-op complications. There's a low, very, very low risk group of patients. Then there's a group of patients at the top of that curve who might have a between 0.5 and 1% risk of mortality. And then there's a longer tail of patients who have a higher risk of mortality, going out all the way out to more than 10 or 15 or 20% risk of death. So all you're doing by using a risk prediction tool is you're superimposing a whole bunch of other little normal distributions along this curve. And what you can see is that if you use a good risk prediction tool, one that has been shown to be accurate in terms of its discrimination properties, and I'll come to that again in a moment, then you can see that the normal distribution for each of the point estimates of risk that you have, 1% risk of death, 2% risk of death, 0.5% risk of death, that's quite narrow. So if the patient has a predicted risk of death of 0.5%, you can be reasonably confident that that is their predicted risk of death. However, when you get out there towards the right-hand side, that long tail of the high-risk patients, all the work that's been done to develop these risk prediction models has been based on much smaller samples of patients, because fewer patients, thankfully, are very high risk. And therefore, your normal distribution at that end of the tail are much wider. Your bell-shaped curve is much fatter. And therefore, there will be a greater margin of error in your point prevalence estimate of risk for those patients. This is summarized nicely in this paper, which is free to access, published in Nature Journals Digital Medicine, led by a group from Imperial, where it highlights in emergency laparotomy patients that if you have a predicted risk of, say, 10% using the NELA model, there's quite a wide error margin around that estimate for that higher level of risk, whereas at lower levels of risk, the models are much, much more accurate. So which risk prediction model should you be using? This is a systematic review that was published in Anaesthesia Journal last week. It looks at pre-operative risk prediction models for 30-day mortality risk and found that the surgical outcome risk tool is the best in terms of combining good predictive performance with clinical usability. It's not super complicated, but it is accurate. And these papers compared, this paper compared the SORT and the SORT clinical judgment with the PPOSM model and some other models, and found that it was superior to that. And the PPOSM was the market leader previously, but we would suggest that the SORT now surpasses that and uses a much lower number of variables. So the surgical outcome risk tool, available at sortsurgery.com, is free to use, and it uses only the type of procedure, whether or not it's a cancer procedure, the urgency, the patient age, and whether or not it's thoracic or abdominal surgery as the predictive items. So they're all available preoperatively, and you can incorporate clinical judgment into that if you wish to. Why would you incorporate clinical judgment into using an objective risk model? Well, of course, the perfect risk model might include every conceivable risk factor, not just those 6 that I've listed that the SORT includes, but also stuff like smoking, alcohol, socioeconomic status, health literacy, patient activation, psychological health, and on and on and on. But complex models like that are very, very unlikely to be used. And we also don't have enough data from previous studies in order to develop models like this. So the clinician judgment bit accounts for all of that. And both the NISQIP model at the top there and the SORT now include that option for you to add a little bit of additional risk and your clinical judgment in order to account for some of those things that are not measured by the risk models themselves. So why is all of this important? Well, the do's of using clinical risk models. It enables you to identify very low risk patients with a high degree of confidence. So if you're implementing this at the early screening phase, for example, it might lead you to consider whether the patient needs a face-to-face preoperative assessment, or whether they can just have a chat on the phone with somebody or by video call and save them a trip to hospital to see a nurse or a doctor. It also enables you to consider if the patient who is low risk could be treated in a high volume, low complexity hub without, for example, on-site enhanced or critical care services. It also enables you, broadly speaking, to identify the higher risk patients, the ones that you might want to, for example, select for enhanced or critical care, particularly on the day, because if you have the common situation where you've got 10 patients having elective surgery who have been booked for a post-operative critical care bed, and there are only 5 beds available, it enables you to line the patients up in order of risk and then identify the 5 patients who would be the most likely to benefit from that post-operative critical care. And then you can make a clinical judgment about whether or not it's safe to proceed without the critical care bed for the other 5. And then the second reason why identifying high-risk patients using these sorts of models is important is it enables you to consider a further shared decision-making process with the patient. So the really, really important don't is that however good a risk model is, it's never, ever going to be perfect. And so you mustn't use a risk assessment tool on its own to make, for example, go, no-go decisions about surgery versus not, particularly in the emergency setting. What it'll enable you to do is identify the high-risk patients, see that, for example, with an emergency laparotomy or a hip fracture patient, that they've got a 10, 15, 20% risk of death, and then have that conversation with the patient, with their carers, with your clinical colleagues, in order to come to make a decision that everybody considers to be right for the patient in front of you. So my conclusions here about risk assessment: it's a basic part of good clinical care. It's not a single event, it's a continuous process. And formal and objective risk assessment is not a panacea. So when you do a risk assessment, do it and write it down. Discuss it with the patient and the surgeon, because they may have information that you don't have. Use your clinical judgment as well. And of course, as you go along a patient's pathway, continually reassess their risk. Thank you for listening. I hope you enjoy the rest of the webinar, and back to the chair. Thank you.